Hi, this is Leonard Kish with Health IT TV. I'm here at HIMSS 16 with Ed Park, the COO of athenahealth. How are you doing today, Ed?
Terrific to be here.
Great. So the big news last night was Secretary Burwell announced the pledge among a number of vendors and providers to increase interoperability and increase patient access to data. Athena is part of that, along with Epic, Cerner. So what do you think of the pledge, and where is that going to take us in health IT?
Look, I think it's great. I think it's great that everyone's getting together and saying we're all going to interoperate. And candidly, I think it's simply yet another move in that direction. Right. I think one of the questions to ask is why would Secretary Burwell have actually asked for this pledge to begin with? Like, what caused her to actually ask for this? And I think the data is not flowing today. Like, we're 20 years into the birth of the internet, and we still don't have data flowing between providers, much less between providers and patients.
Right.
So I think it's a great thing. I think I'm glad that we're all at least saying the same thing now, but I'd love to really move forward and see this get placed into some sort of action.
Right. It seems like some of that might have been driven by Congress. It was clear in a lot of the HELP Senate committee hearings last year that at a congressional level, they were getting tired of hearing excuses about why interoperability and patient access isn't happening.
Yeah, I mean, well, look, we spent $32 billion on health records that we then woke up and said, well, these things don't talk to each other. And so I think it's not surprising that Congress is saying, well, look, I expected that in this day and age, these things would talk to each other, and let's go make that happen. Right.
So last time you and I talked, we talked a little bit about the transition to value-based care, and that might also be driving some of this. The $32 billion, it's often been said, was actually supposed to be a groundwork done for value-based care.
Yep.
Is that happening? Is that some of what's driving this as well?
I think that if you'd asked the question to folks 3 years ago about the transition to value-based care, there were still a lot of sort of qualifying those statements, like if we actually move to this thing called value-based care. Today, I think there's much more of a when. So 3 years ago, the ACOs were an experiment. So accountable care organizations were an experiment. It was unclear whether or not it was just another acronym that was destined to die. At this point, we have over 700 ACOs in this country, and it's clear that they're going to keep going. What's even more clear is that CMS is going to continue to use both its bully pulpit and the power of the way that it pays for healthcare to continue to push for value-based reimbursement.
Right. And so what's Athena doing along those lines? You perhaps as a cloud-based company are more easily able to adapt, but your foundations were in enabling reimbursement for fee-for-service. So how are you making that change for your customers?
It turns out that the transition to value-based care is very, very complicated. It sounds great at a very high level, right?
Right.
So at the very high level, you go for fee for service to volume-based or value-based reimbursement, fee for value.
Right.
But if you look under the covers, the ACA, which had a lot of the basis of value-based care in it, had 906 pages of legislation. Since then, there have been an additional 20,000 pages of regulation clarifying the ACA. If, for example, you look at PQRS, the value-based modifier, which is one of the early stages of an overlay of value-based care, there are millions of ways you can submit for a PQRS. And then you have the Medicare Shared Savings Program, you have Medicare Advantage. Athena, with our nationwide network of 75,000 docs, powers a bunch of the ACOs. We power a bunch of the docs through those kinds of value-based reimbursement mechanisms and make sure that at the end of the day, the clients actually profit under risk.
Great, and that's often at the top of the line. You've heard it in the hallways a lot here as one of the big concerns for hospital CIOs and anybody responsible for the bottom line.
Well, I mean, look, it's a huge shift. Right? Yeah. So one day that you were actually paid for the MRI, the next day you come in and that MRI actually counts against you in terms of the way that you're paid. Everything about the way that your systems operate change.
Right, and it also requires knowing more about patients and requires them the ability to have more access for patients to have that data. or at least for that data to move around with the patients as they move from provider to provider.
Yeah, very much so. I think that many of the most successful ACOs actually cross organizational bounds, and so you need providers to be able to access this information across organizational bounds, and you also need for patients to be able to have access to their own data so they can make the best choices for them.
Right. So I want to ask a little bit about, first, I've been reading Jonathan Bush's Where Does It Hurt? Book about fixing the healthcare system. And some of the really interesting parts are actually about the birth of athenahealth and how it's evolved over time. I'm sure for you it's been a crazy ride as a co-founder and building it up to a public company and now moving into hospitals. So tell us a little bit about how that's been and what you're looking forward to now. The success you've had and what you're looking to fulfill, maybe what's unfulfilled about the vision.
Well, I'm proud of where we've come. If you look down from where we started in Jonathan's basement with a bunch of mosquitoes and a half-dead cat, we've come a long way since then. But I still think that we're at Everest Base Camp, and there's a long, long way to go in trying to make healthcare work.
Right.
We still spend more on healthcare than we spend on almost any other part of our economy. We spend more on, this year we're going to spend more at the physician office than we'll spend on cars. We just spend an enormous amount on what we're doing here. And so, I think that and we try to instill this in our employees that healthcare begins with a relationship between a provider and a patient. So the thing that I see that's the most exciting is that we've spent the last 15 years networking the provider side or trying to network the provider side. Mm-hmm. That's why we have the 75,000 docs across the country. They can talk with each other. All is good there. They have an electronic medical record that they don't hate. Right. So that's a good start. The part that I'm excited about now is how you connect that to patients and what patients will then do with that information. And that is going to percolate to every other modality that we use across the continuum. So as you look into stuff like hospitals, we think that's very important for us to make sure that we keep that idea of this relationship between the doctor and the patient in mind.
Right. And as we'd mentioned, that's key for precision medicine and the precision medicine initiative that's happening, because you need a really more complete picture of an individual.
Well, it turns out that it's very hard to make structural advances in anything related to healthcare if you can't talk to each other. Right. So one of the most fascinating things about the precision medicine initiative is that at least the first stage of it has turned into an interoperability initiative. Right. Because it doesn't matter if you can get 1 million folks to raise their hand and say, I would like to donate my genetic and genotypic and phenotypic information for the purpose of science.
Right.
If you have nowhere to put that,
no context about the
and
individual.
The patient can't actually say, the fact that a patient can't go into an office today and say, look, I'd actually like to share my genotypic information and my health records with someone else. The office is going to look at them and say, what are you talking about?
Right. Until
that becomes easier, we're still going to have a long way to run.
Right. And last thing I want to talk about is Dave Chase and I have been working on this thing called the 95 Theses for a New Health Ecosystem, and you've contributed to that. And it's somewhat related to what we're calling the quadruple aim, the triple aim being about cost, quality, and experience, but the physicians were left out.
Yeah.
That's been kind of a cornerstone to Athena, and had a big marketing campaign. There'll be a party tomorrow kind of based on let doctors be doctors. So that sounds great as a marketing term, but doctors, I think Malcolm Gladwell said, don't want to be a cog in the insurance industry.
Yeah.
So if getting them out of that cog role is letting them be doctors, if that's what you're after, how are you doing that?
Well, I said earlier that we believe that healthcare starts with a relationship between a doctor and a patient. But I didn't sort of say that it includes an insurance company and sort of that mix, lawyer on the side here and a government official here who are in the middle of that exchange.
Right.
And today, the big issue, doctors still love taking care of patients. Is why they became doctors to begin with. What they hate is they hate having to document every last thing they do in an EHR. They hate that if they happen to do something wrong, that they'll go to jail. They hate the defensive part of it. They just want to take care of patients.
Yeah.
And so the way we think about it is to carve away the frustration means to carve out all of that additional work, all of those voices in the doctor's office that are not contributing to patient care. And there's a lot of it. There's an incredible amount of legislation and an insatiable appetite, it seems, from the government, from the insurance companies, from the regulators to keep adding more of it. And we think of our job as trying to keep all of that out of the exam room.
Great. All right. Well, thank you very much. This has been Leonard Kish with Ed Park at HIMSS 16 with Health IT TV. Thanks. See you soon.
Thank you.
Thanks, Ed.